Hi, everybody, and welcome to this edition of the Taking Control of Your Diabetes podcast. I am one of your hosts, Dr. Jeremy Pettis. I'm joined, as always, by my good friend and colleague,
Dr. Steve Edelman.
So, as always, our little background is that Steve and I have both been living with type 1 diabetes since we were 15. We're now endocrinologists, work at the University of California, San Diego. And Steve founded this not-for-profit, Taking Control of Your Diabetes, almost 30 years ago now. It's good to be here with you, Steve. So, Steve, what's our topic today?
Yeah, it's a really important topic that you and I could honestly say we do not know that much about, is bone health and people with diabetes. What are the risks? How to prevent them? Everything that's important to know. And we have one with us, one of our colleagues, Gina Woods, who was a fellow at UCSD, that I'm proud to say I was the fellowship director, and right along your story as well. And Gina has gravitated towards making this one of her areas of interest.
Mm-hmm. So we'll have Gina say hi in a second, but I think that's kind of a fun history is that, so for people that don't know, you go to medical school, you get your medical degree, then you do your like a 3-year residency in internal medicine. And if you want to go into a specialty, you do what you call a fellowship. And so to become an endocrinologist, you have to do 2 years of this specialty fellowship training. And Gina and I actually were fellows together at the same time under the tutelage of a wise Dr. Edelman. And so Gina's here, who's an expert in bone health. And we're talking how it's so interesting that endocrinology is such a wide area that because it is a hormone specialty, it touches kind of every part of the body from the thyroid to, insulin is a hormone. So diabetes is under endocrinology, adrenal diseases, thyroid diseases, and we have a bone specialist. So Gina, say hi, introduce yourself, and tell us how you got into bone disease.
Yeah. Hi, Jeremy. Hi, Steve. Thank you so much for having me. I'm really excited to be here today. I got into bone disease, I guess, when I was a fellow. I was just interested in the fact that the bone is an endocrine organ. I never really knew that. It produces hormones and responds to hormones, and I just thought that was pretty interesting. And was fortunate to work with some great mentors, and just the more I got into it, the more I got into it. So
was Steve one of those mentors, or?
Of course.
Yeah. Well, you know what? I work with Gina every Tuesday at the Veteran Affairs Diabetes Clinic, and I am impressed how well you're versed in diabetes and other areas, thyroid and bone. And you're going to be heading up a new bone clinic, I hear, as soon as you can organize that.
Yeah, that's one of my goals, is to develop a bone health center at UCSD. I do run the osteoporosis clinic at UCSD currently.
And actually, Gina is now the chief of our whole division. I don't know if we can talk about that yet, which means that she's technically our boss.
You just did talk about it.
So our boss is here with us, so we got to, act right, Steve.
More work, no increase in pay. How does that sound?
Sounds
well,
great.
Let's get into it.
So why is this an important topic? So when we say bone disease, what we generally are talking about is osteoporosis and helping people avoid fractures, broken hips, broken spinal, bones, things like that. But why is this particularly important for people with diabetes?
Well, it's important because people with diabetes are at higher fracture risk than people without diabetes, but they are often not identified as being at risk for fractures. They're often not screened for bone disease or offered treatment. So I was really happy to see that in the 2024 update to the ADA standards of care, a lot more attention was given to bone health.
Jeremy, have you ever been screened for bone health? We not. Played.
Have you?
What's that game we played where you put your hand on the dots?
Twister.
We played Twister and we didn't break anything. Is that a screening test? No, seriously, I've never been screened. Now, that was one of my questions looking at your notes beforehand. Should we differentiate, when you say at risk, is it type 1, type 2, men, women?
Well, good questions. Overall, women are at higher fracture risk than men. The statistic is that in the general population, 50% of women over the age of 50 will have a fracture in her lifetime. And the rate in men is about 20 to 25% of men over 50 will have a fracture. So fractures are very common. And, they cause pain, disability, reduced quality of life. And, in the later years, hip fractures are often the beginning of the end. So those are things we really want to prevent.
Well, I'll just say real quickly, it's a dumb question, but when you say fractures, do you have to be hit by your spouse, or do you fall off a curb, or are they just spontaneous fractures, stepping off a high step? I just don't know.
Yeah. So Generally, we call a fragility fracture a fracture that occurs with low trauma. So a fall from standing height, but that could be, walking your dog and tripping and breaking your wrist. That's a fragility fracture. A healthy bone shouldn't fracture in that circumstance. But a lot of times those types of fractures associated with activity are not recognized as being a sign of bone disease.
Now I want to, Steve asked, so type 1, type 2, are they both at risk or?
Yes, both are at risk.
Damn it. Jeremy, add that to the list of things we're going to get.
Well, I was going to say that, a lot of times it can be frustrating when people say diabetes, and they usually mean type 2, and us type 1s don't know if we fall into that category or not.
Or vice versa.
But this is one thing where we actually all are blood brothers and, at high risk of bone disease, whether it's type 1 or type 2. So this is really for everybody out there listening who has diabetes. But, which leads me to my next question is, so why? Why do people with diabetes, why are they at higher risk of fractures? Why is this another thing that we have to worry about?
Yeah, good question. We don't fully understand all the reasons why, but from research that has looked at the architecture of the bone, we see that in general, people with diabetes have more pores in their bone, which make it more likely to fracture. So if you think about like ripping a piece of paper out of a pad, if that paper is perforated with little holes, it's easier to tear. So same applies to bone. We do know that having higher A1C is associated with higher fracture risk. So whether, well-controlled diabetes really is a risk factor, we don't really know.
My sister being a reporter for the New York Post, she's always into the question. So she would say, why do the bone have holes in them?
Well,
and if you don't know, you don't make it up like I might.
Yeah, I don't really know the answer to that. We know a couple things about what's happening in the bone of people with diabetes. So we have cells that build our bone and cells that break down our bone, and we actually rebuild 10% of our skeleton each year. So we think of our skeleton as a fixed structure, but we're building bone, we're breaking down bone. As we get older and in women, as our estrogen drops, we really start breaking down a lot of bone. But in people with diabetes, the bone building cells seem underactive. So whether that's due to, insulin or other growth factors, it's not really clear, but the bone building cells are less active. And then, of course, the advanced glycation end products associated with high blood sugar have adverse effects on the bone.
Yeah, we'll talk about ways to prevent that near the end and talk about hormones in particular.
Yeah, so when I was doing my flash reading before this podcast, it was kind of clear to me that, yes, better control is better in terms of your bone health. So if you're listening and you have diabetes, certainly getting your blood sugars under control is one thing that you can do. But it's not clear if you have kind of good control, your A1C is less than 7, can you make that risk, 0 or the same as somebody without diabetes? We don't know. And there are some things that like heart disease and diabetes, that even if you control your blood sugars, people with diabetes still have an elevated risk, and we don't exactly know why. So there's still kind of a lot of questions in this area that I think is interesting, but it is kind of a bummer. This is something that we have to look out for.
I'm going to get screened tonight.
Well, that's kind of my next question is, okay, so people are listening, they have diabetes, maybe they're freaking out. I don't want to break my hip, et cetera. Who should get screened? When? What are the guidelines for that?
So I would say anyone with diabetes should get screened at age 50. And if bone density is normal, then you may not need to be screened that frequently. But in general, routine screening is recommended for all women starting at the age of 65, but women between 50 and 65 should be screened if they have any risk factors. So diabetes is on the list of many, many things that are considered risk factors: having low body weight, having had steroid treatments, having autoimmune disease. There's many risk factors. So many women over 50 should be screened. I think 65 is probably too late to start screening. We're missing a lot of opportunity to intervene if we wait till 65.
Screening is so important. We screen patients for kidney disease, eye disease. We screen for high cholesterol levels. And so many of these things are written in our notes and reminders and what we call our template to make sure we don't forget. And it's ingrained in our minds, but I've never screened anybody for bone disease. Now, I have ordered DEXA scans, some of the tests you're going to mention in a second, but these are women who already had a problem.
So you mentioned women. So basically, if you're listening, you have diabetes, you're female, anybody over 50 should get screened. And we'll talk about how to do that. What about men?
Yeah, men are underscreened big time for osteoporosis. Medicare doesn't cover routine screening for men. They cover it for men with risk factors. So again, diabetes being on that list of many risk factors, I think men over the age of 50 with diabetes should also be screened.
So, Steve, you're just, what, 1 or 2 years overdue?
Well, my question is, when you get to a certain age and you haven't had a fracture, do you still need to screen? Let's say you're over 65. No.
Well, we should, you know what you should do? You should get screened, and we should film it, do the process, and,
Okay.
what it was like to get it done and things like that. It'll be fun.
Well, let's
We'll
talk
add
about
on.
the test, Gina.
Yeah. So
Sure.
how do you get? So first of all, I guess who would do that? This is your primary care doctor. Do you have to see an endocrinologist? Who would you
don't
talk
have
to?
to see an endocrinologist. Your primary care doctor can order a DEXA scan. It's called a DEXA scan. It's a bone density scan. It's a very simple procedure. It's a low radiation dose X-ray of your lower back and your hip. It's quick, safe, inexpensive, easy to do.
And I would say it's easily read because they have so many standards. Like I don't want to get into the numbers now, but there are normal, there's abnormal, and there's osteopenia, there's osteoporosis, just kind of like with different categories of obesity,
Yeah.
normal, overweight.
So we'll talk about the results, how to interpret them, but real quick, this thing takes kind of seconds, right? And it's essentially an X-ray, maybe a couple minutes, but
Couple minutes,
just
yeah.
to allay people's sometimes people hear an imaging procedure. I have to go to get this procedure done. Do people ever have concerns about getting it done to you, or is that not a problem?
People ask about the radiation exposure. It's less than a standard X-ray. It's about the equivalent of, I think, 2 cross-country flights. So if you wouldn't worry about flying back and forth to the East Coast a couple times, then you shouldn't worry about
Well, I am now. Jeez, that's radiation I'm getting
exposure
from.
of getting a DEXA scan.
I've gotten 6,000 X-rays in my life.
Okay, so then, like Steve was saying, so somebody goes and gets this, special X-ray, and the results come back, and there's categories. So there's specific numbers that you look at that you don't have to necessarily get into, but how should somebody kind of interpret this with their doctor when they get it done, let's say the first time?
Sure. So there's 3 basic categories of results: normal bone density, osteopenia or low bone mass, and osteoporosis. So I will just mention that we diagnose osteoporosis based on a T-score of negative 2.5 or below. But in people with type 2 diabetes, we would consider them to have osteoporosis if their T-score is negative 2. It's a different cutoff.
Oh, I didn't know that. Is that a relatively new update or?
Yes,
Okay.
because the bone density of people with type 2 diabetes is higher overall than people without diabetes, but their fracture risk, so the DEXA scan underestimates the fracture risk. So if you just went based on that T-score, you would think they're fine, but really you are missing the opportunity to
So it's misleading in people with
It's
diabetes.
misleading, correct.
I'm not even going to ask you why because we probably don't even know. But
There's some theories, but yeah, it's
So is that on most reports that it'll say 2.5 osteoporosis, but if you have diabetes?
Nope.
No.
I doubt it.
nope,
Yeah.
I doubt
So then, do most primary care doctors know that?
probably not.
Yeah. So that we're probably still really under screening, one,
Mm-hmm.
and under diagnosing osteoporosis.
Yeah, I would say this. That's one of the reasons I founded TCOID is exactly the title, taking control of your diabetes. And for you listeners here, you could be gentle with your caregivers, with your doctors. They may not know, they may not have been educated. Some of these guidelines are new. It's no problem that you should ask them. You can get screened, and you've heard that this is part of screening process, and that's so important for people to take charge.
Absolutely.
All right. So you get your results. Normal makes sense. We kind of all know, I guess, what normal is. What does osteopenia mean versus osteoporosis? Is that kind of in terms of risk of fracture, or how should people think about those different categories?
Yes, exactly right. So the fracture risk is related to the bone density. So having osteopenia would be a higher risk than normal. So it's a gradation. People in that osteopenia category, if they have other risk factors or have had previous fractures, they still might benefit from treatment. So your doctor would assess your bone density in combination with other things to decide if you should be on medicine for your bones.
And when does that transition happen between primary care and a bone specialist? Can most primary care doctors, quote unquote, handle osteopenia, osteoporosis? When does somebody come to see you, I suppose?
Yeah, most primary care doctors can. I mean, the sad truth is there's not enough bone health specialists to treat everyone. So primary care doctors do a lot of of the evaluations and treatments, and they are qualified to do that. But people who have had recent fractures, especially hip or spine fractures, or whose bone density is not improving with treatment, should see a bone health specialist.
Well, you mentioned not improving with treatment. How often should you get a bone density test, a DEXA scan?
So generally every 2 to 3 years if you are on treatment for osteoporosis. And if you don't have osteoporosis and you get a screening test, you should still get rescreened at some point in the future. Usually, I'd say 3 to 5 year intervals.
So then we can talk about treatment once, like you have a diagnosis, but everybody wants to avoid that diagnosis.
Correct.
So maybe we should talk about prevention first of, how much calcium should I be taking, or vitamin D, or what kind of diet or exercise? That must come up all the time.
Yep.
And add in there, what other drugs do people take that could make osteoporosis worse, including diabetes drugs?
Yes. So let's start with nutrition. Calcium is very important for bone health, so everyone should get at least 1,000 milligrams of calcium per day. If you're older or you have osteoporosis, that should be 1,200 milligrams per day.
And that's from the diet or just total?
Total.
Okay.
We try to get as much as you can from your diet. It's easier to absorb the calcium from food than it is from supplements. And there's been some concern about possible risks of supplements. But really, the main thing that supplements increase the risk for is kidney stones. So taking high amounts of calcium pills can cause kidney stones. So
Are there any particular brand that you could recommend that we could ask to be sponsors of TCOID after this podcast?
I'll have to think about that. I don't know. What's your favorite brand?
Those
Viactive?
Viactive, yeah.
Yeah.
Chocolate or caramel, I can't tell which one I like better. The problem is, if I start eating them like I enjoy them, I'm going to get kidney
Well,
You're
stones.
gonna get
that's why you
kidney
have all these kidney stones. Yeah. So there's no age that you would say every woman needs to start taking a calcium supplement?
No, it depends on your diet. I mean, if you drink 3 glasses of milk a day, you don't need a calcium supplement, although not many people do that anymore. But milk drinking is associated with better bone density. So
I drink a ton of milk.
Gina, I know you do. You take cholesterol meds, doesn't matter. What about vitamin D? The Viactive has D and potassium, I noticed on the label. But is it important to take a certain amount of vitamin D along with the calcium?
I would say yes. Vitamin D deficiency is common. Vitamin D is not found in many foods. It's in egg yolks and mushrooms, but not that many foods. So I would say I think it's important for everyone to we're supposed to all get 600 to 800 units a day. More than that is safe. And a lot of the calcium supplements have the vitamin D right in them. So it's easy.
Okay.
Yeah, there was a craze once where everyone was measuring in our diabetic patients' vitamin D levels, and it always seemed to be low. Even in San Diego, where you get a lot of sun, and that's supposed to help.
Yeah, but in the winter, even in San Diego, we don't get enough UVB radiation to make enough vitamin D. And as we get older, our skin is less efficient at making vitamin D.
So getting a combination calcium, vitamin D sounds like a good thing.
Yeah.
Mm-hmm. So the other big part that comes up with prevention is, it's incredibly common in postmenopausal women. So the discussion's always been around, should I take hormones postmenopausal? So I know that's been a kind of a big debate, but where are we at right now? If you're postmenopausal, should you take, estrogen supplements?
Give us the one-liner of what.
Hey, I just asked a question.
This is part of your question.
Okay.
when the estrogen was vilified, causing cancer, and then take us 20 years up until the current time.
All
Is
right.
that okay, sir?
Yeah.
Well, if you haven't heard, menopause is having a moment. If you have been following the news in the last year, a New York Times reporter named Susan Dominus did a great piece on menopause. It was called Women Have Been Misled About Menopause. It went viral. Another podcast, probably not quite as popular as this one, The Daily, put out by the New York Times, produced a piece on it.
It's a little startup podcast they got over there.
So if you're interested in the topic, I highly recommend listening to that Menopause is Having a Moment podcast. We're really trying, in my field, in bone health, we're trying to turn that moment into a movement and really re-educate doctors and patients about hormone therapy. So more than 20 years ago, before the Women's Health Initiative, hormone therapy was the most commonly prescribed drug in the U.S., hands down. And lots of observational studies looked like estrogen was beneficial, lots of benefits. So pretty much all women at menopause were given Prempro. We had never done a randomized study. That was done. It was stopped early due to concern for harm in the hormone group. This was like a bomb dropping on the medical community, and prescriptions for hormones plummeted. And really, the medical community kind of threw up their hands, and they stopped.
And the risk was like clots, and what were some of the risks?
So cardiovascular, blood clots. There was concern about breast cancer. Mainly cardiovascular events and breast cancer risk. But, like all studies, it's complicated, and you have to really dig into the data to understand it completely. And so now we've had over 20 years to do that. And what's become clear is that the timing that you start hormones is really important. So starting hormones as close as possible to the time of menopause is much safer and has a lot of benefits. So I'm not saying everyone should go on hormones automatically, but every woman going through menopause should at least have the information and be given the choice.
Yeah, all three of us were at UCSD when very world-famous individual Elizabeth Barrett Connor, who was the one involved in those early studies, and even Cindy Stunkel, who's still there. It really has changed 180 degrees from being awesome to being deadly. Now it's coming back.
Yeah, we're trying to, be reasonable, kind of find a nice middle ground. But the problem is, in the last 20 years, we stopped teaching doctors how to prescribe hormones. Mm-hmm. So women are going to have to advocate and ask for the information.
So
I'm going to spare our listeners of the only joke endocrinologists have.
Here we go. Just
I'm not going to say it.
Edit this out, Eric.
How to make a hormone. I'm not going to say it. But could I ask about testosterone?
Yes.
What's the role of testosterone?
So testosterone is also important for bone. And men who have low testosterone are at risk for osteoporosis. So,
and people with diabetes are high risk of low testosterone. Add it to the list. Another thing.
Yeah.
So then, men with at a certain age with diabetes, we talked about this, should probably get screened for low T based on their symptoms, things like that. But certainly, I guess if a man comes in with a low bone density, it's something that you would check.
Yeah.
Yeah,
for sure.
All right, so. Before we get in again to specific treatment for osteoporosis, since this is, a diabetes podcast, are there things that come to mind, particularly for people with diabetes, whether it's prevention or certain diabetes meds that they should avoid? Anything that comes to mind that you want our listeners to know?
Oh, yeah, I forgot to talk about exercise. We were on nutrition, and then we skipped right over exercise. So exercise is super important for bone health. But it's not just any exercise. You have to know what type of exercise is going to benefit your bones. My favorite study is called the Lift More study. It was done in Australia, where they randomized postmenopausal women with osteoporosis and osteopenia to do this high intensity impact and resistance. I'm sorry, I have to edit this out. Anyway, high intense HIIT training, basically. So they were doing deadlifts,
CrossFit kind of stuff.
Yep, deadlifting, power squats, jump drops,
flipping tires and stuff.
Basically,
pulling tractor trailers with their teeth.
No, but this is something that's reproducible that people could do. You don't need to
and that woman puts out an exercise program, right? You told me about that.
And then she had a control group, and they did lower impact exercises, and both groups exercised 30 minutes twice a week for 8 months, and the HIIT group had improvements in their bone density, and the other group's bone density went down. So it's basically two things: strength training, and it needs to be moderate or high intensity. So when we say that, we're saying you have to be lifting weights or doing some kind of resistance training that feels hard, and you can do like 6 to 10 reps, but it's challenging.
Okay.
It can't be light. And then impact. So impact exercises are where one or both feet leave the ground and then return to the ground.
That's the NBA.
Yeah. So that impact on the bone is what stimulates bone formation.
Okay. And so the thing we really worry about is hip fractures. So are you trying to do this strength training specifically in your legs or back, or does it matter?
You want to target all the major muscle groups. And obviously, this type of training has a lot more benefits. It will help your bone, but it'll also help you preserve your muscle, because we also lose muscle as we get older, and also just help us to be more functional.
Okay.
Wow.
Yeah. Well, Steve, you got a lot of work to do. You got to get screened. We got to adjust your workout regimen.
Gina, one of my last questions is, what do you know about menopause? Because Jeremy's got a bad case of it.
No comment.
Okay, so talk us a little bit, let's say you get your DEXA scan, you're screened. they give you a diagnosis that is, concerning that you have low bone mineral density. You need to go on therapy. What's kind of your first line treatment? Talk through some of the options people have.
Sure. So the treatments for osteoporosis fall in two basic categories. Anti-resorptives, which stop the bone loss that's happening, and anabolics, which stimulate bone formation. So for people who have osteoporosis based on their bone density but haven't had fractures and their T-score isn't very low, they could take a bisphosphonate like Fosamax. That's still the most commonly prescribed drug. It works. It got a bad rep, but the problem with Fosamax is you can't take it for too long. So usually you take it for 5 years and then you stop it for a few years, and it is very safe and effective. For people who have had like spine fractures, for example, we would recommend one of the bone builders. They're they're injections, but they are very effective at rebuilding the bone.
Yeah, one of the things that's been fascinating me about these Fosamax type medications is that you can take them once a week, some are once a month. Mm-hmm. There's even an IV that you can get that's like once a year,
Yep.
sometimes every other year.
Mm-hmm.
So I don't know. It's a nice feature to not have to take so many pills.
Yeah, for sure. And, especially when, adherence and persistence is a tough thing. And I've heard about there's only a certain amount of time that you take it, like you mentioned, but these anabolic ones, these are monoclonal antibodies, some of these newer drugs. And I'm just guessing they have to be expensive.
Unfortunately, they are expensive. So
name a couple just so.
So Forteo and Tymlos are both daily injections. They are PTH analogs, so they act on the parathyroid hormone receptor. Very, very effective for improving spine bone density, preventing fractures. It's a 2-year course of a daily sub-Q shot. Mm-hmm. They are expensive. And then the newest one is called Evenity. That's a monthly injection for 12 months. That is a monoclonal antibody. Coverage insurance-wise is a little better with that one, and it's really effective. I mean, it's great to have such effective tools in my toolbox.
I'm surprised about Forteo because that came out years ago.
Yeah.
And it's not off.
There's a biosimilar, but unfortunately the cost hasn't come down as much as we hoped it would.
Well, it sounds to me when you get to this stage, sounds like you need to see a bone specialist with these newer drugs, these monoclonal antibodies, the anti-resorptive,
If you have very low bone density, like a T-score of -3 or lower, or you've had fractures, then yes. But otherwise, Fosamax still works for people who have mild, kind of early osteoporosis and want to try to reverse it. You can still do that with Fosamax.
And then talk about kind of monitoring, because what I remember is that, let's say you go on Fosamax and you get your bone density tested another year or two, that your bone density might not change at all, but you're still being protected and your risk of fracture is going down. So how do you coach people through like not getting hung up on these dexas? I mean, how do you talk about that?
Yeah, it's a little tricky, but even if your bone density stays stable on treatment, that still means your fracture risk is reduced. And I like to show people a picture of the bone density scan because it has this nice graph that shows this line that's sloping down, which is the average bone density with age. So what I tell people is we're all going down. We're all riding that line. So even if you just, stabilize, that's winning. You're still, stopping that bone loss.
Yeah. Well, I think there are like so many treatments now. And like, I didn't do my fellowship with you that long ago, but even since then, I think things are continuing to change. And it is nice to see this real overlap now with diabetes appropriately. So you mentioned the ADA, which is the American Diabetes Association. They release these guidelines every year, everything, what medications we should be using, how we monitor CGM pumps, whatever. Is this the first time that bone's made it in there? Has it been there a while or?
There was a brief mention of bone in last year's edition, but this year it got several pages.
Okay.
Yeah, someone on their committee had an interest in bone. And it went from like, yeah, you should keep an eye on your bone to 3 pages of information, most of which we're covering now. So I agree with you. Mm-hmm. Like since when does the ADA get involved in bone? But it's obviously important.
Yeah. And we should put it in our little note templates, like you said, that I always have blood pressure there, cholesterol, so I don't forget it. And
Make
adding
sure
bone, something else to do.
Anyone on insulin gets glucagon.
Yeah.
Just a whole list of things. And we talked about this in clinic yesterday. The list of things that we need to remember are getting longer and longer. But the bone health is important, really is. And I'd say especially for women, but also for us guys too.
Yeah.
So are there anything you want to leave our listeners with when it comes to maybe a message of hope, I suppose, or some good news in this area?
Sure. There's lots of research going on. I mean, we have lots of effective medications, but in addition to that, there's a lot of work going on looking at nutrition and bone health, medical foods for bone, exercise. I think that with all this research going on, we're going to have a lot of great options for preventing loss of bone and muscle as we get older.
Well, Gina, I learned so much from just reviewing the notes and doing this podcast with you. And Jeremy, I'm impressed how much you know about bone.
It's like I can feel the cobwebs coming out of the back of my brain somewhere.
Me too.
Yeah.
My cobwebs solidified.
Well, thanks, Gina, so much. And thanks, everybody, for listening. If you like it, make sure to share it, like it, send it to friends. And we enjoyed doing this. We'll see you at the next one.
Thanks, Gina.
Thanks for having me.